All right, so here's our first case. 56-year-old gentleman, right-handed. 3 years prior had this fracture. He apparently had a history of alcoholism and drug abuse, so he was just treated with a sling and went on to get this malunion, as you can see here. So I treated him with a reverse arthroplasty. Quick question, would anybody have done anything other than a reverse in this patient? Okay, so I think that's a good case for reverse. So here's the patient at 2 weeks, sutures out, implants look to be okay, discontinued the sling and started physical therapy. 2 days later, comes back to the emergency room looking like this. So I'll start off with Julie. So what is going through your mind in terms of what you want to do initially? You take all these people to the OR right away? Do you give them a try, closed reduction? What do you think?
Well, first of all, I'm sad because I'm typically on vacation and this comes across as a text message and ruins my day. I mean, I really do try to think about the patient, think about the factors, think about their personality and what they might have contributed to it, or was the therapist overly aggressive. But ultimately, I will always do a closed reduction and not go to the OR the first time.
Okay. Kevin, any comments?
Yeah, so I definitely agree with that. I think that this is one person you worry about, patient factors, alcoholic, falls a lot, maybe some compliance issues on the patient's part, proximal humerus malunion. These are ones that even preoperatively you're worried that there's going to be a risk of instability, but I agree with Julie. I think especially in the acute period, acutely after surgery in the first couple weeks, I think a closed reduction attempt is your first step.
Okay, so I would agree with that. Put the slides back on. So we did a closed reduction, put him back in a sling, told him to stay in the sling, and sent him home. Comes back 4 weeks later, claims to have been in the sling, been compliant, and your x-rays like that. So, Matt, if he's been in the sling, do you think they really can dislocate when there's a sling? You think they're non-compliant, just lying to you?
I think he's probably non-compliant. I'm not sure somebody like this is going to make it either way, but the orthopedic non-compliance rate is roughly 50%, according to some studies. In alcoholics, it's probably 150%. So he's not going to do what you're asking him to do, most likely. But, I don't know that somebody who's coming out this frequently, this early, I'm not sure there's anything you can do. I mean, at some point he's got to take his sling off to shower and do normal things, but given the patient risk factors, this person, it's almost like veterinary medicine. You got to treat him, as best you can, knowing that he's going to do nothing that you ask him to do.
All right. Sammy, do you think there are times when patients do stay in the sling and can dislocate, things you caution them against in the perioperative period?
No, I mean, I really think you've bought the patient. I mean, this patient's higher risk because of his history. You're trying to do the right thing, and I certainly, you try to encourage them to stay in the sling, but as I think you've just heard, non-compliance is pretty common, and it's probably very common in this age group.
Yeah, so one thing I have found, I think there are sometimes patients, if they lean on that elbow to like roll over in bed or to help get up, those patients can dislocate. I think even trustworthy ones who say they stay in the sling, so we always caution them not to roll over, not to try and lean on that elbow because they adduct, extend, and I think that's certainly a potential mechanism for them to come out. So Dr. Hatzidakis, this guy's now come out twice. What do you want to do for him?
Just a question about his exam. So I think a careful exam is important. How's his axillary nerve function in your mind, Richard? Normal sensation, normal?
It's intact, yes.
Intact. Well, he's failed twice, or at least once, I guess, with the reduction. And in my experience, closed reductions don't often work when a dislocation occurs this early in the process. There's something else going on. Usually with tensioning, perhaps sometimes with medialization of the glenoid component. Doesn't look like we have that in this case. Does he have any neurologic disorders or any other things besides his non-compliance?
No. Nothing else.
Can I make a general comment about, so those really stiff patients, the malunions and so forth, once you put an arthroplasty in them, those soft tissues can stretch back out. Like once that shoulder starts moving again, because I don't think that was moving much before. It looked like almost a static sort of posterior locked kind of subluxation type situation. So once those soft tissues start moving, they will frequently loosen up. Those are the ones that will show up in my office later dislocated even when I put them in as tight as I could. So like a cold fracture, like I see a lot of cold fractures coming in 3 weeks, 4 weeks out that I put an arthroplasty in. Those soft tissues have really contracted, and once I put them in as best I can intraoperatively, they're gonna stretch back out even more, has been my experience. And so that's a difficult population because you can put them in as tight as you want, but they're still gonna accommodate because they've not moved in so long, and once they start moving, and I don't know the answer to that because I can't put them in any tighter. But the good news is frequently it's just a upsizing of the poly, so it's a really simple fix, but it's a reoperation generally.
The other thing I'd like to add to that is that in cases of malunion, these are tricky because of the alignment of the stem. You could see it on the axial view is different than what we usually do. It's different. The relationship between the greater tuberosity and the cup is different than usual. So a lot of times that makes it more difficult to dislocate. In general, sometimes I have to osteotomize the greater tuberosity to even do this case, and I think it may be playing a role in the instability here as well.
Yep, so I think it's a great point that Matt brought out. In addition to what he said, you have to often do a lot of soft tissue dissection because they are very, very stiff, and so you're doing a lot of releases to try to get this reduced, and so you've done a large dissection. You sometimes get some hematoma, and I agree with you that things do stretch out, and they're kind of a setup sometimes for that.
And obviously, I mean, you did the surgery, so I'm sure as a gifted surgeon, you have to, though, if you're seeing someone sent in from somewhere else, you've got to be careful about a case like this if you're doing an adequate inferior capsular release, because you can actually get paradoxical sort of springing out. And the solution is not to add a poly, but to actually potentially do more of an inferior capsular release. And the other thing, too, the malunion, the greater tuberosity, you're not going to have the same deltoid wrapping. If you see on the Gracie view that the greater tuberosity is obviously mostly posterior, so you're not going to get that same deltoid wrapping effect.
Any other comments? Right. Go ahead.
I'd say one thing for, kind of along what Samer was saying is for the greater tuberosity, especially the ones that are malunited and they're always a little posterior, I really tried to debulk that pretty well, because if you leave some of that bone posteriorly, I really think that and some of that thickened inferior capsular tissue can impinge, especially in that externally rotated adducted position. And I think that's something you have to really assess intraoperatively. Did you get all of that?
Right, so that's a great point because I was concerned about that. You've got all this back here you're talking about, and I thought we'd got sufficient amount of that, but I was a little bit concerned. You can see here on the post-op film, maybe I left a little bit more than I should have, and that certainly can be contributing to his instability. So for most people then, you give them one shot at a closed reduction, and if it fails, then you're talking about surgery, correct? Everybody agree with that? Okay. And in this case, soft tissue tension's an issue we talked about. Bony impingement's an issue we talked about. Any other concerns and things you're going to want to address when we go in there? Kevin?
I think the only other thing you could consider would get bilateral full-length humerus films to check your length here, because obviously with the malunion, some of your regular assessments are off. So I think with length could be assessed with bilateral scanograms.
Yep. The other thing I have difficulty sometimes deciding is when do you accept the malunion, just put a stem in, and when do you decide that you're going to have to take it down, use a fracture stem, osteotomize the tuberosity, and refix it. And that's sort of I do on a case-by-case basis. I felt this time here we didn't need to do that. Whether that would have made a difference, I'm not sure. But Julie, any thoughts about that?
I mean, I really would say I try to not osteotomize the greater and the malunions. I think the times when I do or have done it is because there's absolutely no way I can get any kind of stem in unless I do. But I feel like it's under so much tension and it's so contracted that I don't think it's going to heal if I osteotomize it and try to reconstruct it.
Good. All right. So we did take the patient back to the operating room, and we went ahead and just basically added 5 millimeters of poly, trimmed a little bit of the remaining malunited fragments. Anything anybody else would have done when they were in there? Any other considerations?
Did you take cultures?
Did not.
Mm-hmm. And I would just say I've had 1 or 2 cases that dislocated in early, 6 weeks. As soon as they come out of the sling, dislocated. Really couldn't see anything obvious. Dislocated again, took them back, and there was a sizable effusion, which you could attribute to just the dislocations, but then they very rapidly grew C. acnes. And I don't know how that contributes, but probably does.
That's a good point. Anyways, this guy stayed in. These are post-op films. At 1 year, had 150 degrees of elevation, 30 degrees of ER, and R to L3. Strength's good and has been compliant since that time. So,
Richard, could you just explain to the audience what you do to test your stability at the end of the procedure when you have your implants in? What tells you that this is stable enough?
well, that was going to be my question to the panel here. Right. So, how do you, that was the next thing I was going to bring up. How do you assess stability at the end of the case to determine if you're happy or not? So I've heard people all over the place. Some people like to put it in and have a millimeter or two of shuck. I'm not in that crowd. Some people like to make it so tight that it thunks in there and you're stuck and it's hard to get it out. So I personally prefer to put them in really tight. Julie, what's your preference?
I mean, the first thing I try to do is, when I get in there, can I recreate it? And it's interesting, I don't know if you found this or the others, but there's definitely times where I cannot do it. I have it all opened up and I can't figure out how is this happening. I try to recreate all their motion, and I think it's something about the deltoid firing that I cannot recreate. But if I can't really figure it out, then I really try to make it as tight as possible, especially if it's a non-compliant type patient.
Right. Kevin, what are your criteria?
I think one thing is your exam under anesthesia first off with these dislocated patients can be helpful too, to see if it's reducible or relocatable, and that'll kind of give you a clue of maybe what the problem is. And as far as getting your stability, I think again, I probably don't put it in that tight, but I think in a situation like this, you're trying to get stability, so you're gonna try to put it in a little bit tighter than you usually do to try to gain some of that. But again, if you put it in too tight, then you can and leverage it out as well. So there's a problem that I think sometimes if you put it in too tight, that can lead to instability as well.
Matt?
So I think the most overlooked reason for dislocations is the impingement, right? So Dr. Frankel's group wrote that nice paper in 2017, loss of containment, loss of compression, and then impingement. The loss of containment is like a failed, glenosphere. It's pretty obvious. The loss of compression is soft tissue or acromial fractures. That's pretty obvious too, right? You just get in, it's loose, and you upsize the poly. It's the impingement on other structures, be it soft tissue or bone, that's frequently missed. Those are the ones that usually get referred to me. And if you go down the checklist, usually that's the culprit in the difficult case that hasn't been able to be stabilized. The one you just showed is different. I think that was a loss of compression because he stretched back out. But at the very end of the case, the number one, the way people dislocate is getting out of a chair, right? The at-risk position is adducted, internally rotated, so when they push up this way. So I'll reproduce that, but I'll also hook my finger on the front edge. So I'm really trying to stress that position. And if they won't come out there, second most common is forward flexion and distraction. So when they reach to lift like a bag of dog food or something. So those are the two positions I'll check intraoperatively, and if the patient's stable there, then they're probably fine. I get a lot more stress fractures than I get dislocations, so maybe I'm putting them in too tight, I don't know. But the dislocation rate has been fairly low in my hands. Stress fractures I get, we all get, but.
Samer?
Yeah, I think there's really two populations. I think for primary, you're right. I think dislocations are very uncommon. And in our journey over the last 2 decades, and I use a lateralized center rotation implant, but we're putting them in looser than we did 20 years ago. We're not doing the full lateralization, and yet our dislocation rates have dropped, likely because of improvements in our technique and trying to strike a balance. I think for revisions, it's on a case-by-case basis, and clearly you got to think about factors including everything from neurologic to deltoid wrapping to other considerations as well.